Take the driver's seat, reduce your cholesterol. I'm Randy Wachter, the Vice President of Marketing and Business Development for North Kansas City Hospital and Meritas Health. Thank you so very much for joining us today. Before we get started with Dr. Brown, I'd like to go over a few housekeeping details before we start. We've muted all attendees to help reduce feedback. So if you have questions, please submit them through the Q&A feature by clicking the icon at the bottom of your screen. Our speaker will answer questions at the end of the presentation. Today's topic focuses on cholesterol. In just a few moments, Dr. Michael Brown, a family medicine physician with Meritas Health in Smithville, will talk about the serious health risks associated with high cholesterol. He will share a few unhealthy habits that cause high cholesterol and offer some simple ways you can lower your cholesterol level. It's my pleasure to introduce Dr. Michael Brown.
Thank you. It's my pleasure to be able to be here today and to talk to you about this very important topic that affects all of us. In fact, some would say it's one of the most universal and most prominent diseases that is experienced by humans across the globe. Just a few more basics about myself, just to kind of give you a basic introduction. I am board certified in family medicine and clinical informatics. I practice in the town of Smithville, Missouri. I am the president of the Missouri Association of Osteopathic Physicians and Surgeons, which means I represent all of the DOs across the entire state of Missouri. My family life, I have 7 children, which keeps us obviously very busy. I tell my patients I like to go to work for rest and relaxation so that I can get ready for when my real job starts at home when I go home. By hobby, I'm from a family of beekeepers. My father was a beekeeper. I keep bees and my children do as well. And I like to stay healthy by running. And I tell people that I'm not a very fast runner unless I'm combining my healthy habit of running with my beekeeping skills. And when things might go wrong during that hobby, you'll see me run much faster than other times. So they kind of mix well together. So let's just dive right into cholesterol, what it is and why we need to be concerned about it. The first question a lot of people may ask is, what is cholesterol? It's a term that's used in the world so much now that sometimes we don't even know what it is. But cholesterol is a type of a lipid or fat that's measured by your physician, along with triglycerides, which is a common type of fat in your blood. So typically you'll get lab results which will show total cholesterol, LDL or bad cholesterol. In medical school, we remembered that the LDL was the bad cholesterol because we remembered L stood for lethal. That's how I remembered L was bad. And then you have your good cholesterol, HDL, and we remembered that the H was for healthy. So you want your lethal cholesterol, your LDL cholesterol, to be low, and you want your good cholesterol, your healthy cholesterol, HDL, to be high. To better introduce the different types of cholesterol, I thought we'd share this great video from the American Heart Association, which really points out the differences between these different lab values that you may be getting from your physician.
Dr. Brown, we've had some audience members tell us that they can't hear the audio on the video, so if you could just continue.
Sure. Well, I'm sorry that's not working for you. If you go to YouTube, just go to the American Heart Association and type in or actually on YouTube, type in AHA for American Heart Association and what is cholesterol. But I encourage you to watch it. I'm sorry that didn't work well for you because it's actually nicer to see the animations than it is just to hear me talking. But that's okay. I can function without it, and I will move right along here then with the presentation. So let's talk about why cholesterol is bad for you. What the video was trying to show was that as cholesterol builds up in your arteries, it actually forms these little plaques that you can see in this picture here on the right. And that obviously is clogging up that pipeline of essential nutrients and blood flow to your body. And clogged blood vessels are going to reduce the blood flow to very important organs within your system. And we have specific names when cholesterol starts to become a problem at certain areas of the body. For instance, when your cholesterol starts to block up the arteries around your heart, we call that coronary artery disease. And that can lead to severe symptoms such as heart attacks. When cholesterol is blocking the blood vessels around your brain, we call that cerebrovascular disease. And this is one of the common things that can cause strokes. There's also a rare condition where the cholesterol will block the peripheral arteries, which these are the arteries that go to your arms or to your legs. And when those are blocked, it actually causes severe leg pain or arm pain when you're actually trying to use them, such as going on an extended walks or long walks. You'll start to have pain because you're lacking blood flow to those limbs. These are just three things that an increased level of cholesterol can cause, and they're reasons why we try to prevent cholesterol buildup within your body. So how bad is elevated cholesterol for human beings as a species across the world? Well, high cholesterol is said to be associated with at least 1/3 of all heart attacks that we experience. 2.6 million deaths worldwide a year are associated with having too much cholesterol. This is a great little graph that's really just intended to show you how cholesterol affects the world. And you'll notice that it's really a disease of developed countries. So in the Americas and Europe, you see much higher risks of high cholesterol than you do the rest of the world. And then these four areas on the right just show you that it's actually a disease that the higher your economic status, the more likely you are to have high cholesterol. Now, the reason I'm showing you this is not to get too much into the science of it, but to show you that this shows that cholesterol problems are a lifestyle problem. If it was just simply genetic, you would see it much more across the board. If it was something we couldn't do something about, you would see it very even across the world despite socioeconomic status. But because we see it increase as economic status increases, we know that cholesterol has a strong lifestyle component to it. And that's something that we can possibly alter and make some changes to. So what are some causes of high cholesterol? As we just discussed, lifestyle. There was a very famous cholesterol medication advertisement that went on several years ago where it said, you might be having bad cholesterol because of this, or you might because of Uncle Bob, or because of an Aunt Jane or something like that. Well, I want you to know and really emphasize out of this lecture is that we got to stop blaming Uncle Bob. What happened from that ad campaign is patients came to me and said, I have high cholesterol, but there's nothing I can do about it because it's from my aunt or my uncle. It's from the genes that I have. But the reality is that's only a very small part of what causes high cholesterol. We know that cholesterol is elevated, and that's why I showed that last graph for you, is just to kind of show that it's really associated more with lifestyle. So unhealthy diets, lack of physical exercise, smoking or secondhand smoke exposure, and excess weight are all associated with elevated cholesterol levels. Now, there are hereditary components to cholesterol levels. There are many people who have high cholesterol because of Uncle Bob. But I'm letting you know, and again, emphasizing that's the small part of people with high cholesterol. Most people, it's going to be because of lifestyle issues. So what about diet? And then I asked this question, may I eat eggs? Eggs seem to get batted around left and right. You can eat eggs today, you can't eat eggs. You can eat eggs, you can't eat eggs. So I'd like to answer that question. For diet, mainly what we're told to do is to avoid saturated and trans fats in your diet. These seem to be the fats that are associated with cholesterol the most. Dietary cholesterol, that means cholesterol that you take when you eat into your going into your stomach does not really seem to affect the individual's cholesterol. Meaning the cholesterol I eat doesn't seem to increase my own cholesterol. So eggs, though they're high in cholesterol, are actually low in those bad saturated fats we just talked about. So therefore, eggs are kind of back on the menu. They say in a limited portion, but eggs are back on the menu. At least they are today, until we get some more evidence and some more data. As we know, things can change frequently. Um, I have this quote here from the Harvard School of Public Health. I really like it. It says, "The biggest influence on blood cholesterol level is the mix of fats and carbohydrates in your diet, not the amount of cholesterol you eat from your food." I think this is really important, and this is a new area that might not get as focused on by some of your physicians. But not only is it the cholesterol and the fats that I'm sorry, not only is it the fats that you're eating, but it's the carbohydrates in your diet, and it's that mixture. And this explains why I can have people go on a lower carbohydrate diet, which involves a lot of fats because they're eating more meats, but they still lose cholesterol. And I think it's because they decrease the carbohydrates. This is also why someone can go on a strict low-fat diet and they can decrease their cholesterol. They're eating a lot of carbs, but they aren't having a lot of fats. So it's the mixture of the two together. So if you want to think of the classic example, the Krispy Kreme donut, that's the epitome of bad evolution, where we have a deep-fried fatty food that is covered in sugar and therefore is going to increase your cholesterol. Now, I share this little slide here for you. This is a nutrition label that you see on the back of all foods in the United States. And it's really important to recognize where we should be focusing on. So that first row with the total fats, that's going to break down anytime you have saturated or trans fats. And so those are the things that we just discussed are the foods that you want to avoid, the saturated and the trans fats. I tell people to think of them like simple and complex sugars. So the saturated fats and trans fats are bad for you because your body doesn't have to do any work to process it. And so it loves it. It's just like a simple sugar. Whereas the monosaturated or the unsaturated fats, which we'll talk about in a bit, your body has to do a lot more work to break down. So it actually uses energy to use that energy. And so therefore, you're not accumulating as much of it as you would. Now, the other part that you need to pay attention to is the carbohydrates. So notice that this food here is high in carbohydrates and it's high in saturated fats. So this would be something that we want to avoid. The part that you can almost ignore, I wouldn't say completely ignore, is this cholesterol line right here. We talked about that. And it used to be that we thought that if we ate a lot of cholesterol, we'd get a lot of cholesterol into our body, but we're showing that that's not true. In fact, it's actually been argued that they'd like to remove this line from nutrition labels and just focus on the fats and the carbohydrates. Maybe more data on that's coming out in the future and we'll make those changes. But again, focus more on the saturated and the trans fats and the carbohydrates if you're looking to decrease cholesterol in your body. So now let's talk about different treatments. And the first thing to talk about when we talk about treatments is, do we really even need a treatment? Where do we start with your cholesterol? So the first thing I recommend to patients is that we get checked by your primary care physician. I get a lot of patients that call me and they'd like me to just check their cholesterol. That's it. Put in a cholesterol lab, let me go get it checked. Your health fairs at work will let you do that. They'll just check your cholesterol and that's it. The problem is that the decision to start cholesterol medications is not based on the numbers. It's based also on the risk factors. Those numbers are, while they're important, don't mean as much to me unless I've had a discussion with you about what your risk factors are and whether or not you need a treatment. So those risk factors can be things like diabetes. What is your current blood pressure at the time? Do you have any history of kidney disease? History of cigarette smoking, and then also family history of cardiac disease at a young age. So this would be if you had a father who had a heart attack at the age of less than 55 or a mother who had a heart attack at the age less than 65. This would be called an early cardiac disease history, and that's something that we would factor in to making a decision whether or not you need a treatment. So I really encourage you to get together with your primary care physician. Don't just get your cholesterol level checked, but have that full discussion so you can get the right treatment. treatment. Now, if you're just going by the numbers, these are some what I call generally desirable levels. So these are some decent guidelines, but they don't give the full picture unless you meet with your physician as well. So your total cholesterol, if you're less than 200, you're generally doing good. If your bad cholesterol is less than 100, you're generally doing good. And if your HDL is greater than 60, then you're generally doing well as keeping your triglycerides less than 150. But now the question is, when do we want to treat? When are those numbers a problem? They're outside of those generally good guidelines. When do I need to know if I need a treatment? Again, I circle back to it's all about your risk factors. And so people with previous disease are going to be at much higher risk than other individuals. If you've had a heart attack in the past, you've had a stroke in the past, or if you're diagnosed with diabetes, you're at increased risk of heart disease, and therefore your treatment guidelines are going to be different. They're going to be a little bit more aggressive because you're going to benefit more from having these treatments applied. Now, some interesting things about treatment. What's our goal when we start treating a patient that has elevated cholesterol? Really, right now, the data only supports treating that LDL numbers. I always give my patient good advice for increasing the HDL. There's some natural ways to do so, but the best way to increase the HDL is aerobic exercise. The American College of Cardiology recommends 30 minutes of moderate exercise 5 times a day. That will increase your HDL. But the problem is that when we look at the long-term data, fixing that HDL just doesn't show much clinical benefit, which is decreasing heart attacks and death. So, but what we have shown very good significant improvement in those factors is if we treat the LDL, we lower that lethal cholesterol level. So the guidelines kind of vary, but here's a rule of thumb I give to patients. And again, the guidelines kind of vary depending on what doctor you're talking to and what specialty they're from. But this is the easiest I remember, which is 100 equals 10 times 10. And that means if the LDL is greater than 100, and their 10-year risk of having heart disease, meaning having a heart attack or some kind of negative effect from your high cholesterol, is more than 10%, then it's time for you to try some kind of treatment. So just remember that. If your LDL is greater than 100 or your 10-year risk of heart disease is more than 10%. And I'm going to teach you in this, this lecture here how to actually find out what your 10-year risk of heart disease is. So you can take your numbers and you can calculate your 10-year risk of heart disease. Some other general guidelines. These are just general guidelines. Typically, if the LDL is greater than 160, at that point, we usually have a treatment that's recommended regardless of what your risk factors are, because you're getting pretty high at that point, and we've shown some good benefit regardless of your risk factors. Also, if your risk for having a heart attack, this is the gray area of medicine. This is where having a physician help guide you through this process is very useful. If your risk of having a heart attack is between 5 and 10%, then we need to participate in what we call shared decision making. And we'll talk more about that later. But that's basically you and your physician making a decision whether you personally think you should start the treatment or not. Also, just something to throw in here is that if you are in that kind of, do I need to start one, do I not need to start one, there are some great tools out there, including one that I like, which is called a coronary artery calcium scoring test. And you can actually get that done through North Kansas City Hospital, and I shared the link there. You can schedule it yourself. I typically pull it up with my patient in the room, and we put their information in, and they've got a phone call before I've even left the room to get it scheduled. So I strongly encourage that. If you're on that fence of do I need one or do I not need one, this is one of the tests you can discuss with your physician. You actually don't even need an order from your physician to get this done. Also, if your risk is less than 5% of having a heart attack or some kind of heart disease in the next 10 years, then typically a statin therapy, which would be a medication therapy, is not recommended. Now, I didn't say no therapy is recommended. I'm just saying a statin therapy might not be recommended at that time. So let's talk about what those treatment options are. The first one, since we talked about that most people have high cholesterol because of lifestyle, is to change the lifestyle. And so I recommend this to all patients. Those are things such as losing weight, weight loss, and getting involved with more aerobic exercise, diets that are lower in saturated fats, Now, I will tell you, these do have benefits, but they are kind of small, so they have small benefits. So the results can be small, and so you have small benefits from the lifestyle changes. I wish I could say that by doing all of these changes, you're going to bring that cholesterol right back into normal, and it may be for you if it's not that far off. But there are going to be many times where you're going to need something other than a lifestyle modification to help you. A lot of times what I'll do is I'll start patients out on a lifestyle modification. We'll bring them back in 3 to 6 months. We'll recheck it. And if we're not getting the improvement that we want, then we'll go on to another type of treatment. So what is that kind of treatment? Well, right now, the standard of care in medicine is to use what's called a statin therapy. Now, statins online, I have lots of patients bring this to me, have good news and they have bad news associated with them. And the bad news is usually the side effects. But I will tell you this, the good news is these medications are amazing when it comes to treating patients' cholesterol and amazing when it comes to reducing the risk of heart attacks and strokes in these individuals. They do work, but they do have side effects. And we're going to talk about those side effects so that way you can be aware of them and you can make a good decision with your physician. So first off, going back to lifestyle modifications, what are some very specific things I can do to help reduce my cholesterol? Well, the good news is losing body weight actually really does reduce your cholesterol. In fact, only 2% body weight loss can reduce your LDL by 5%. Patients come to me and they say, sure, Dr. Brown, I'd love to lose weight. I'm going to lose 100 pounds. And I think that's a great goal, but I tell my patients to start much smaller than that. I usually tell them 5% body weight. Let's start with that. Then we can keep working forward towards that ultimate weight loss goal, because I've shown that just 5%, in fact, I've even shown just making the changes to try to start losing weight brings the cholesterol down even when the patients might not have even lost weight yet. And so just making those changes usually involves decreasing that saturated fats, decreasing carbohydrates, and so I see the cholesterol change even before I see the weight loss change occur. Aerobic exercise, as I talked about before, 5 days a week, 30 minutes each time for 150 minutes total a week. And it's moderate exercise. And I tell people moderate exercise means you're going to start sweating. If you don't have to take a shower after your moderate exercise, then you probably didn't get into the moderate exercise level. It's not hot and sweaty like extreme exercise, but it's at least enough that your body start having to make some physiological changes to adapt to that exercise that you're doing. And I'll give you some examples in the future here. Now, lifestyle modifications also include limiting saturated fats. I'm going to keep coming back to that. So here's some great examples from the Cleveland Clinic about what moderate exercise is. Walking 2 miles in 30 minutes, biking 5 miles in 30 minutes, swimming laps for just 20 minutes will get you that moderate exercise level. Doing water aerobics for 30 minutes. I strongly recommend water-based exercising for my patients, particularly my elderly patients. They do very well with it. I had one woman just tell me yesterday, thank you so much for referring me to water aerobics. I feel like I can run again. She loves going into the water and she gets out, she gets a good exercise, and she doesn't have all the joint pain and the joint aches that are associated with it. So if you have access to a swimming pool, which I know is very hard right now during the COVID timeframe though, I really encourage it because these are great exercises for individuals. Playing volleyball for 45 minutes, playing basketball for 20 minutes, washing your car for 45 to 60 minutes. I suppose if you have a large enough car and it takes you that long. Gardening, I love gardening. I recommend it to patients. 30 to 45 minutes of gardening is considered some moderate exercise. Raking leaves for 30 minutes. Dancing for 30 minutes. So you can see there's a lot of recommendations here, and not all of them involve just having to go out for a run or go on a bike or go to a gym. There are many things you can do to get this moderate exercise 5 times a week. So saturated fats, rather than give you a big long list, I gave you a visual aid here. Most of us, I think, know which fats we need to avoid. They're the things that mom have always told us to kind of go easy on. Bacon, processed foods, sausages, also your dairy products, your creams. These kind of things are full of saturated fats. Butter. These are the things that we want to try to avoid in our diet. What are our good fats? Yes, unfortunately, the unsaturated fats don't have as many pictures available because they're a little more limited, at least in the American cuisine. These are going to be the things that are recommended in what is called the Mediterranean diet. You'll hear cardiologists recommend the Mediterranean diet a lot. These are your cold fish, your salmon, and then your oils such as your olive oils and things like that. individuals that get put on these Mediterranean diets do so much better with their cholesterol, and it's because they reduce their saturated fats. Now, once again, I'm circling back to this nutritional facts label here for you. And this is just to highlight again, remember, this is the line where you can find your saturated and your trans fats and your carbohydrates, and you want to reduce both of those to help control your cholesterol level. Now, let's say we've done the lifestyle modifications and we're just not getting those results that we were looking for. Well, then it might be time to have the discussion with your physician about starting a medication. Again, I told you the data is really good behind these medications. So if you need a pill, what are your options? Again, the gold standard is going to be your statin medications. This is your Crestors, your Lipitors, your simvastatin, etc. They're very effective. They used to have a problem because they were not cost effective, but all of these medications now have generic alternatives, which make them very cost effective. Even if you were paying cash for them, they're usually quite affordable, and most insurances cover them, but they are not without side effects, and we're going to talk about those. There are other specialty options that are available, and so if you can't tolerate a statin, you'll want to talk to your physician for an individualized approach as to what kind of medication you would work for you if you can't tolerate the statin medications. So, what are the side effects of statin medications? Nausea, stomach upset, etc. can be associated with them. The big one right here is muscle pain. I warn all my patients before starting this that they might have muscle aches or pains. There are plenty of good studies that show only 5% of patients on these medications get muscle aches or pains. The problem is that we typically start these medications in an age of life where muscle aches and pains tend to be common, despite being on these medications. And so what happens is I'll start a patient on a muscle or a statin medication. They'll have muscle aches and pains 6 months later from working too hard in the yard, and they'll come to me and tell me they can't tolerate their statin anymore because of this. And so we have to do a good history with them to determine, is it really the medication, or is it because of something else that you did? So we got to be very careful with that. But if you are having muscle aches and pains, we'll talk about later about ways to deal with that. Headaches can be common with them, dizziness, and there are other reactions as well. Overall, again, these are very well tolerated by most of my patients. It is recommended to take them in the evening so that it avoids some of these side effects. There is a very rare risk of muscle and kidney damage with these statin medications, and any physician that starts you on these medications usually will be checking your labs regularly so they can make sure that you're not experiencing any of these extreme side effects. So now I want to talk about what I alluded to earlier, which was the shared decision-making process. How do you and your physician come together to make this decision process? So if you'll bear with me for a second, I am going to try and get out of this slide. And we're going to go over here. This is a website that anybody can go to. There are many different versions of this, but I like this one the best. And this is called the Statin Decision Aid by Mayo Clinic. And it's literally just statindecisionaid.mayoclinic.org. And it will let you go and take those lab values that you got with your physician, from your physician. By the way, one of the things I love about Meritas Health is that we give access to our patient to their labs almost before their physician even gets access to them. It comes very quickly. And you can go online and you can open up your chart through our patient portal, and you can find these lab values, and you can put in all that data into here, just like I would do with the patient, and you can see what your risk factors are. So in this case, we're going to have a 55-year-old male, and we'll just make him Caucasian, and we'll say he's not a smoker, he's not diabetic, but we'll say he has high blood pressure, but it is controlled. It was 128 when he came into the clinic for us today. His HDL was a little low at 35, and his total cholesterol was a little high at 225. So now we're going to hit current risk. What this will do is calculate his 10-year risk factor, and it puts it in a graph, in theory. Well, okay. Well, what it would do is put it in a graph that would work there. Let me try it one more time. We'll try it one more time here. I may change some of these values here. You can be at home putting in your own values if you've got them and see what they look like. Cholesterol, we said he was 35. Total cholesterol 225. There we go. So now we've done the 10-year risk factor, and we have happy faces and we have sad faces, but we can see that he has a 10% chance of having a heart attack over the next 10 years. So we talked about this is in that range of maybe we need to have a discussion about some kind of treatment. What's great about this, I said this was shared decision making, so let's talk about interventions with this patient. If you click this little intervention right here, I'm going to put him on a standard high dose statin medication. How does that change his risk factors? Well, now you'll see that we've decreased his heart attack risk by 4%, and we've gotten down there. So now he and I can have the discussion about whether or not this is going to be a valuable treatment plan with him or not. And what makes it even easier is you can click this little issues button. So now we've got before and after, and in the middle, we have the different downsides or side effects of the medication. The common side effects we talked about, the muscle aches and pains, liver damage that we talked about, and what those risks are. So we could say, you know, in this case, the patient might say, look, I got a 4% decreased risk of heart disease, but I got a 5% chance of having muscle aches and pains. Maybe I don't want to do that medication. And if that's the decision we make, that's the decision that we make. But it allows them to make a decision based upon what data we have. So feel free to put your own data in here, and then you can take it out if you want to print this screen or something and bring it to your physician and have that conversation. I totally recommend having that conversation with your physician. And that's called shared decision making. So lastly, what I wanted to talk about, I called it the bonus section, was we talked about those side effects with the statin. Just because you're having side effects, does that mean that you can't take the statin anymore? Does that mean you're out of luck and there's no treatment options for you? Well, first off, I would say talk to your primary care physician about this. Talk to them about what options are available, because there are options available for people that are not on that can't tolerate the statins. For instance, I recommend to my patients that are having some muscle aches and pains, if they're just mild, to take an enzyme that's available over the counter called coenzyme Q10. If you start at 200 milligrams once a day, you usually I can see those side effects go away. And if they don't, I usually will increase them to 400 milligrams or 400 milligrams twice a day. 400 milligrams once a day. And that tends to work for most of my patients having the muscle aches and pains. I had one cardiologist describe this to me as the cure for statin muscle aches and pains. I don't find it work with 100% of my patients, but I do find it work with most of them in correcting that side effect. So have this discussion with your primary care physician. Again, I just want you to know that there are options. It doesn't mean just because you have muscle aches and pains, you should stop your cholesterol medication. Because as we discussed earlier, they show benefit to everyone that takes them. Even low-risk individuals benefit from taking a statin medication. There are also alternate statins that can be prescribed. So you might talk with your provider about which one of those might have less side effects than the one that you're currently on. Another treatment option that's available is what we call alternate day dosing, where instead of taking it every day, we'll have the patient take it every other day. And so that's just another option that's available for you and for if you're having side effects with the medication. After lifestyle changes, if a medication is necessary, we do our best as physicians to try to get you the maximum benefit for that. And there will always be patients that aren't going to be able to tolerate this medication despite anything we try to do. And there are some options for that as well available. And that's something that you'll just have to talk to your primary care physician about the next steps. So with that, I wanted to proceed forward with some questions and turn that over to an opportunity for us to have some questions.
Thank you, Dr. Brown. It does look like we have just a few questions coming in. One participant would like to know, what are the safe numbers on the nutrition labels for fat and carbs?
You know, that's a great question, and I wish I could tell you the answer to that, because it's very different for everybody, depending upon actually what their cholesterol level and their risk factors are. So, you know, I will switch hats here. I'm a primary care physician, so I don't just deal with the heart. I also deal with diabetes and endocrinology a lot. And I went to a conference just a few weeks ago where a very smart endocrinologist was speaking to us. And his recommendation, at least from the sugar standpoint, was if you're looking to lose weight, you need to keep your carbohydrates between 20 and 40 per meal. That's 20 and 40 milligrams per meal. Now, people that do what's called a ketogenic diet will keep it less than 20. I think 20 to 40 is a little more doable doable for my patients. So that's what I would recommend for that. Now, as far as the fat levels, I would say just follow the recommended daily guidelines. So it's hard for me to give you specific numbers, but you saw that there were percentages on there, and you definitely want to keep that below that 100% guideline. So the example we showed earlier, it was already at 23%. And so we would want to make sure that we don't exceed the recommended daily guidelines on the saturated fats. Ideally, I'd prefer you just have no saturated fats. I think that that's a doable lifestyle, and they do it in the Mediterranean, and that's why they have very non-existent heart disease compared to people in the United States.
Thank you very much. Another listener would like to know is drinking a half a gallon to a gallon of water daily good for lowering cholesterol?
I don't know any data behind that. That does seem like a lot of water, but if you're tolerating it, good. I do think Americans are very dehydrated overall. But I have not seen any data that water drinking lowers cholesterol. But I will say drinking enough water is a very healthy thing to do.
Thank you. What are your thoughts on fish oil vitamins?
Fish oil used to be the rage. It was recommended by everybody. You see it recommended less and less. And the main reason behind it is because we just don't see the outcomes with it. So I would leave that between you and your physician. And what I would do is if you're taking fish oil, have your cholesterol checked. If it's helping the cholesterol, then great, it's working for you. But if it's not, then it might not be, what you take it for. I will tell you this, though. Again, I'm a primary care physician. I do see benefits to fish oil and things like mental health and things like that as well. So there are different benefits for fish oil. It is definitely a healthier oil. But what I find is that people taking fish oil could probably decrease their cholesterol better by addressing other parts of their lifestyle and the foods that they're taking than just taking the fish oil by itself.
Thank you. You've mentioned several times to get screened and to talk to your physician. One person would like to know, does Medicare and insurance cover routine screenings?
That's a great question. And unfortunately, Medicare does not cover routine cholesterol screening. This is something that I've always personally disagreed with. And it's something that if you do as well, make sure we're talking to those involved in decisions with Medicare to try to change that. But as of right now, Medicare does not cover routine screening. Now, the ironic part of that is if you get screening elsewhere and you have elevated cholesterol, I can now test you for your cholesterol, and we can do that on a regular basis. So once it's elevated, I can get it and I can test it for you. But until it's a problem, then I can't, Medicare will not cover for it. And you're all at home thinking, well, that doesn't make sense at all. And I promise you, I think the same thing. It doesn't make sense at all. How are we ever going to find out that you have high cholesterol if I can't screen you for high cholesterol?
Got it. How often should I have my cholesterol checked?
That is a good question as well. So most screening recommendations are if it's normal, every few years. If it's abnormal, then every year, depending on how abnormal it is. If it's very out of control, I'll have the patients checked a couple times a year. But if it's under control, but maybe borderline, we'll do it every year. And then those patients that always come back perfect, I'm going to do it every few years just to keep an eye on it. Unless there's some kind of major life event, they're diagnosed with diabetes, have a heart attack or a stroke or something like that. Those individuals are going to be screened much more frequently. Again, it's all based on those risk factors.
We have a few questions that are all related to the actual test and the screening. So why do we need to fast before a cholesterol check? And is there anything that can skew the results?
That's a great question. I love it because it just kind of depends. So I will tell you, the reason you're required to fast is because those triglycerides can alter your results. And triglycerides will show up if you've eaten that morning, especially if you had some kind of fatty food. And it will make it harder for us to see those LDL and those other values of your cholesterol. But interestingly enough, I have read some good studies that show that our lab results have gotten much better over the years. And so fasting isn't as necessary as it used to be. Now, I tell you this knowing that most of your physicians might not be up to date on that, and so therefore they're going to still require fasting. So always follow the direction of your primary care physician. But that being said, on my patients, if they haven't fasted, I still get the cholesterol because my philosophy is a bird in the hand is worth two in the bush. And if my patient's in there wanting to get it checked, I'm going to get it checked that day. And we actually have some new tests that if you weren't fasting and I can't get a read on that LDL level, my lab will reflexively get the second test and get me that accurate LDL level. So it's just dependent upon your physician. Follow their advice and direction. But as of right now, I think fasting is still in, and you might see that change over time.
We've had a few people wonder if alcohol affects the consumption of alcohol affects their cholesterol levels.
So it depends on the alcohol. There is limited or evidence that those people that are part of that Mediterranean diet usually have a glass of red wine a day, and that tends to decrease their cholesterol. But that's pretty much the only studied alcohol I'm aware of. And that's only one glass of red wine. You know, once you start going over that, then you're going to have some problems. And you've got other factors, not even related to the alcohol, that might become a problem. So for my patients, if they want to drink a glass of red wine a day for it, I'm perfectly fine with that. But personally, I just kind of avoid that recommendation unless they bring it up.
What about avocados?
So avocados are full of those unsaturated fats, and so they're actually better. And so I do recommend those. If you're going to replace fats with something, do it with your healthy fats.
For non-drinkers, do you recommend? Sorry, I just lost my screen. One moment. I think it was Resveratrol.
So they
Do you know
think
what I'm
that
talking
that's
about?
yeah. So they think that's, and I can't pronounce it either. So you're getting good there. So they think that that's the part of the grape or the red wine that is responsible for decreasing heart attacks, and I tend to lean in that direction. And because I doubt it's the alcohol itself that's doing it. It's probably an antioxidant, and that antioxidant is most likely associated with the grape. So will it help? I don't know. The problem with it is we don't have enough good long-term data on that. I tell patients if you'd like to do it, great. You know, let's see how it works and let's see how your cholesterol does. But I can't give you any definitive evidence at this point on that.
And I just have a couple of more questions. We appreciate your times, and we know you have to get back to the clinic. Is there any research supporting statins to help prevent Alzheimer's or dementia?
You know, I keep hearing that, but I'll tell you that one is not necessarily in my wheelhouse at the moment.
Okay.
But I have been hearing rumors of that, but I haven't researched it myself.
And I think this is the perfect question to end with. Once you get your cholesterol under control, can you ever return to eating what you used to eat?
You know, let me change that question and see if this answer works for you. Once I get my weight under control, can I ever return to what I was eating beforehand, and my weight will stay under control? And I think you know the answer to that is probably not, and I would say probably not.
Thank you very much, Dr. Brown, for spending time with us today. I know we all appreciated it and learned a lot. And for everyone out there, thank you for joining us today. I hope you gained a better understanding of why lowering your cholesterol is so important to your health. If you ever need advanced heart care, North Kansas City Hospital does have an award-winning cardiac program. Our program is run by an expert team of specialized nurses, technicians, and 14 board-certified Meritas Health cardiologists. While you're looking at the Test Your Ticker website to schedule your calcium score, go ahead and take a look at nkch.org/heartcare, HEARTCARE. Thank you everyone for joining us, and we'll see you next time.